For this week, I'll be presenting a 37-year-old male that presented to UTMC and Patient Recovery Services for opioid dependence with active withdrawal. This patient reports using about a gram of fentanyl daily via IV. Last use was the day before at 5:30. We round typically at like 9 o'clock in the morning, give or take. For this patient, opioids has been an issue for about the last 10 years. He's had several accidental overdoses, with the last one being about 4 days ago. The patient has had 3 previous hospitalizations and 3 unsuccessful attempts at IOP services. Current withdrawal symptoms include restlessness, dilated pupils, stuffy nose, anxiety, and piloerection. Cow's score at the time was 9. Patient denies any other psych history, denies suicidal ideation, homicidal ideation, and auditory and visual hallucinations. As far as medical history goes, he had torn his ACL at about 17 years old, was surgically repaired, and that's really his only medical issues. Denies home medications. Patient has been homeless for about the last year. Denies any legal issues. As far as family history goes, looks like mom had an issue with cocaine and dad had an issue with alcohol. Aside from that, there's not a whole lot of family history to report. Patient reports being unemployed and reports his highest level of completed education was the 10th grade. Patient's been eating and drinking sufficiently on the unit. States he only got about 5 hours of sleep last night and does not feel rested this morning. That's when we look back at nursing documentation, that's consistent. Patient's single. And patient reports having cravings at about 7 out of 10 on that morning, which is pretty typical in that timeline. As far as plan for this patient goes, obviously we're going to manage his withdrawal symptoms as it continues to progress. So using meds like clonidine, gabapentin, Visceral, and he'll eventually start Suboxone at some point. As far as what he's going to do when he leaves the unit, we're currently weighing whether we take another try at IOP or whether we start looking for residential options for this patient. Obviously, with him being homeless, a residential option would probably be the best for him, but also he has to agree to do that, and I'm not 100% certain that he's going to agree to that. We'll do whatever he wants. That's our job, and we'll kind of go from there. But yeah, that's about it. Thank you.